Good afternoon, everyone. Welcome to Exploring the Benefits of Minimally Invasive Bunion Surgery. I'm Caitlin, an account manager at Points Group, the marketing agency that handles UOA's marketing and advertising efforts. I'll be your moderator today and fielding any questions you have to Dr. Schafer. You can type your questions into the questions box in the control panel on your screen. Please note that we will answer questions at the end of the presentation. We will not answer questions specific to your condition. Please visit uoanj.com to schedule an appointment to have your individual condition addressed. With that said, I'd like to introduce our presenter, foot and ankle surgeon at University Orthopaedic Associates, Dr. Kevin Schafer.
Thank you, Caitlin. I'm Kevin Schafer. I'm an orthopedic surgeon that's fellowship trained in foot and ankle surgery, particularly minimally invasive bunion correction, and that's what we're going to be talking about today. So first off, what's a bunion? So a bunion is really a catch-all term for an angular deformity of the big toe, specifically when the big toe goes over towards the lesser toes. And you can see right here, it's not subtle, right? The big toe here is heading over towards the lesser toes. And it can push on the other toes as well, so they can become involved. And commonly, what patients come in saying is that they have a growth on the side of their foot, but in most cases, there's not actually a growth on the side of the foot. It's just that as your big toe changes in alignment, the normal bone or the joint becomes more prominent, leaving that bony bump. And when you get a bunion, the most common symptoms that patients commonly come in talking about is pain. And that's usually at the base of the big toe. So you can see in this picture here where I've circled in red for you, that's the base of the big toe. But sometimes the pain can happen at the other toes as well. And as that big toe drifts over towards the lesser toes, it can shift how your body transfers weight onto the other toes. And in this second picture here in the bottom, you can see what we call a callus, or signs of wear and tear, that second metatarsal or that second toe is seeing more load than it's supposed to, and that can be painful. In addition to pain, it can be cosmetically unpleasing. Your foot can become wider as the toe starts to drift over, and that can make it difficult to wear certain shoes, dressier shoes, or just shoes with a narrow toe box. They can be uncomfortable and they can be difficult to wear. And commonly, because of that, that skin can get irritated. So again, in this top picture here, you can see how the skin is red and angry. Furthermore, there's a nerve that runs right along here. And if that is constantly rubbing against a shoe, patients can sometimes get some numbness along that toe. A lot of patients want to know, how did I get this bunion? Is it something that I did? And the most common question I get is, was it something I did with shoes that caused this bunion? And the simple answer is no. You can see from this picture on the right with a dressier shoe with a pointy tip that it's not really the shape of a foot, which is also shown on that cartoon on the left, right? A dressier shoe with a pointy toe box doesn't really fit the natural shape of a foot, but there's certainly plenty of patients who wear these types of shoes that don't get bunions. And there's certainly a lot of patients who have never worn these shoes that get bunions. So commonly, this sort of shoe can make bunion pain worse, but I wouldn't say in most cases that it has caused the bunion. Some patients also do have a strong family history. Not every patient, but more than half of patients will tell their doctor that they have a family history of bunions. So in some cases, that could be a contributing factor. Other mechanical factors that are described include having a flatter foot, having joints that are more flexible, and having a tighter Achilles tendon. All of these things can alter how your body is loading your foot and can result in that big toe joint changing in alignment. And when we see you in the office, we'll examine you, but we'll also get X-rays. And some of the things that we'll commonly see are that the distance between the first and the second metatarsal here, so I've outlined this with these red dashes, that distance will increase. And the reason that's important is because it can make your foot look wider, and it can make it more difficult to get into a shoe. In addition to those two bones kind of spreading apart, your big toe here, which I've outlined in blue here with the dashes, can rotate over towards the lesser toes. It can push on the toes when it does that, and also this normal part of the first metatarsal becomes prominent, and this is commonly what patients think is an extra bone, and it's really not. It's just that this normal part of the joint is now becoming exposed and rubbing up against the skin. So what do I look for in exam? Well, the most important things that I look for are the severity of the deformity, the flexibility of the deformity, and whether the other toes are involved. So severity of the deformity. If it's a mild bunion deformity, minimally invasive surgery is certainly an option. A lot of moderate to moderately severe bunions can also be corrected with minimally invasive surgery. Some of the more severe, stiffer bunions, however, it may not be the best option. So it's important to have your doctor examine both the severity and the flexibility of your bunion to see whether that's an option. We always try to talk about non-operative treatment before we go forward with the surgery. So if your bunion doesn't hurt you, I always advise watching it. There's certainly no harm in doing that. We can always do something down the line if it becomes more severe or if it bothers you. So there's certainly no harm in watching a painless bunion. But if it starts to bother you, the easiest things to do are to modify your shoes. So if you get a shoe with a wider toe box, or you can have someone do what's called shoe stretching, that can make the shoe more accommodating to the shape of your foot. In addition, if you go on Amazon or you go to a good drugstore, there are hundreds of different types of bunion pads, bunion splints, toe spacers that can help pad that part of the base of the toe that becomes painful from rubbing on the shoe, and that can keep that space between the big toe and commonly the second toe. Additionally, if you have a deformity in your foot, we can prescribe an orthotic to help support that. And then things like Tylenol, anti-inflammatories like Advil, and icing can be helpful to help control some of the bunion pain. What if none of that stuff works? In what setting should you consider a bunion surgery? Well, if you've tried changing your shoes and it's still painful, it's probably a good idea that we talk about doing something. If it's affecting your level of activity, if you enjoy walking for exercise, if you enjoy running, and you're not able to do that because of the pain, then that's a significant reason that it may be a good idea to get this fixed. Even some folks tell me that it makes it difficult to do their job, whether it's climbing ladders or whether it's doing a lot of walking at work. So that's certainly another good reason to think about a bunion surgery. Similarly, balance. We don't want anyone falling because the shape of their foot has changed so much that they feel like they're not steady on their feet. How about reasons when maybe bunion surgery isn't the best idea? Well, in patients who have a bunion deformity and they want to get into a specific shoe that they are having trouble getting into, but it doesn't really cause them any pain, in most cases, I recommend against the bunion surgery. There's no such thing as a risk-free surgery, although the risks with minimally invasive bunion correction are very small. And I always advise patients that if you have a little bit of stiffness and you have a little pain after surgery, and you didn't have any pain before, then you might not be happy. So we can always do something down the line, but in cases where it's a cosmetic deformity only, I usually recommend that patients observe that. Well, if we're talking about surgery, what are we talking about? There's over 100 procedures that have been described for correcting bunions, and obviously we're not going to cover all of those today. We're going to focus on minimally invasive bunion correction. This is a newer technique that I've been trained in where we're able to shift the bones through small poke hole incisions. And that's made possible by these newer instruments. This top left image here shows you what we call a burr. It's a couple millimeters wide, almost like a pen tip. And by just making a small poke hole in the skin, we can introduce that into the foot and we can cut and shift the bone. That's how we correct a bunion. We cut and we shift the bone. So I'll show you an example here. On the left, this is a styrofoam, or we call a sawbones model of a foot. And this is an X-ray corresponding to this model here. And you can see the bone has been cut here so that we can shift this, what we call first metatarsal head, or that big toe joint, over towards the other toes for a more normal alignment. And again, that's all done with a little poke hole incision to cut that bone. After we cut it and we shift it over, we hold it in place. These screws that you see here are also put in through a 4 or 5 millimeter incision. So we're not doing a large dissection to cut and shift the bone or to hold it in place. Sometimes we do another bone cut up here. We remove a little bit of wedge of bone so that we can take that big toe even over a little bit further. Again, all done through a smaller poke hole incision. And the benefits of that are great. You can see this is a patient example 6 weeks after surgery. You can't even really see the incisions. You can see these small little markings where we've introduced the instruments, but the swelling is less. You don't have a huge scar. So just to summarize here, the advantages of bunion surgery: smaller incisions. The benefit of the smaller incisions are that we're not doing a large dissection. The less dissection you do, the less you're stripping the blood supply from your bones. And we think that allows for better healing. It also allows for less swelling. The smaller your incisions, the less dissection you're doing, less swelling. There's multiple studies showing that patients who have minimally invasive bunion corrections have less pain after surgery, which is really important. Also, what's unique about this procedure is that by making these smaller incisions, we're able to stay out of the big toe joint. It's what's called extracapsular, which we think is a huge advantage because anytime you enter a joint and you take down the joint capsule, we worry that it scars in, it'll become stiffer. And because we're not having to make these big incisions and we're just making these little poke holes, we stay out of the joint, and we think that we're able to get better motion because of it. So there's a chance that with a minimally invasive correction, we can preserve more motion up your toe. Very importantly, this is not experimental. There's plenty of studies showing that this surgery is safe. It's as effective as traditional methods. So this is not like you're signing up for something that is experimental. It is new, but it has been studied and shown to be effective and safe. So here's just an example to show everyone. So this patient clearly has a bunion, right? As I showed you on the earlier X-rays, the space between this bone and this bone has increased. The big toe is going this way, at least the first metatarsal is. And then the rest of the toe is coming over towards the lesser toes. And then this is an example of the X-rays right after surgery. So we've cut and shifted that bone, again, through small poke hole incisions, and we've held it in place with these screws. And it may look a little funny. You see this spike of bone here, and you might think, man, is that going to bother me? It seems like it might be a little bit of a sharp edge there, but it's really impressive because if you follow these patients, which we always do at the 6 months or a year, you can see that your body will remodel that bone. It lays down a lot of extra bone on the inside to make that strong, and some of the bone on the outside resorbs. And in some cases, I will take the burr and shave down that little spike so it's not so prominent. But your body does a really great job of remodeling the bone so that it's nice and strong with a better alignment. So this is an example a year out. And then importantly, when we look at your foot from the side, we don't want to shift your big toe up or down because that can result in a difference in how you're loading your foot. So this is just an example showing that we keep that nice straight line of your foot. All right. So again, in summary, bunions can cause pain and difficulty with shoe wear, with your balance, with mobility, and living an active lifestyle. And if that's the case, it would be a good idea to talk to someone about it because it's important to be active and do things that you enjoy in life. Not all bunions need surgery, and if we can get away without any surgery at all, that's great. But if you do need surgery, a lot of the deformities can be treated with these minimally invasive techniques. And it's with these smaller incisions that we're hoping we can have a better experience for patients with less pain, with less swelling, and with better motion. So with that short presentation, I will open it up to questions.
Okay. We do have one question here. Do bunions go away on their own?
That's a great question. They don't. There are a number of braces, straps, spacers that can make your bunion look better. But we know from studying all of those devices that nothing is going to change the history of your bunion. If it's going to get worse, it's going to happen. There's nothing you can do taping it or putting on these spacers that's going to change that. Similarly, it doesn't go away on its own. It can certainly stay the same, and it's hard to predict how quickly it will get worse, if at all. But they don't go away on their own. Good question.
Okay. Can you speak to the differences with bunions and metatarsals? And are they the same issue, or does one lead to the other?
With bunions and metatarsalgia, is that what you say, Caitlin? Sure.
Yeah.
So metatarsalgia is a term that just means pain under the ball of the foot. And when we use that term, we're usually talking about toes other than the big toe, the lesser toes. And as I kind of explained, the bunion deformity kind of affects the whole foot. It changes your whole foot mechanics. I'll go back to an X-ray here just so we can understand things a little better, but you see the size of the first metatarsal, right? It's much bigger than the other toes. It's meant to see about half your body weight. And when the alignment of your foot changes from a bunion, like in this case, your body will shift some of your body weight onto the lesser toes. And we think that's what causes the metatarsalgia. We call that transfer metatarsalgia. In fact, I've seen some patients who have really bad bunions and the bunion itself doesn't hurt, but they just have pain at the lesser toes. But in that case, unfortunately, we do have to correct the bunion to correct the root cause of why they're having transfer metatarsalgia.
Okay. Is this similar to lipoplasty?
I'm not super familiar with liposuction and lipoplasty. That's typically done by plastic surgeons, but my understanding is they do use smaller instruments. So in that regard, it might be pretty similar. But again, the big difference with minimally invasive bunion surgery, and I'll show you the tool again from this picture, right, is it's a very small instrument. And as you can see from this patient after surgery, there's smaller poke holes rather than a big long incision to achieve the goals of surgery.
Okay, so we have a couple questions about recovery.
Sure.
So how long is the recovery? What is the recovery like? Timing of walking, driving, wearing regular shoes again, and can you perform the surgery on both feet at the same time?
Excellent questions. Driving, if it's your left foot, you can drive as soon as you're off of narcotics. If it's your right foot, it's going to take a little bit longer, and I'll go through the typical recovery so we can kind of understand that. So out of surgery, I either have you in what's called a post-operative shoe. If you've ever broken your toe and gone to an urgent care or an ER, you've probably seen what a post-operative shoe is. It's kind of a Velcro strap over your foot with a firm sole to it to protect your foot. And right out of the OR, I let you put weight on your heel. That way you can transfer, you can walk around, and it just makes it easier to have your balance, and there's a less risk of you falling. And honestly, that's why we put these big screws in, is to make it safe to do that. And for my protocol, I like that for a period of 2 weeks. And it's not because the bones aren't ready to handle more stress than that, the walking, but it's because we are cutting the bones and shifting them over. And there's swelling that's associated with that as your body tries to heal that. And I find that if I just slow patients down for a few weeks and keep them on their heel, that swelling goes away faster and that their pain is a little better. Once I see at the 2-week appointment and I take your stitches out, I then let you put full weight flat on your foot, either in a short boot or that shoe. And for the same reasons, I keep you in that shoe or that boot for another 4 weeks until about 6 weeks after surgery. Again, your bones are ready to handle more load than that because of the screws that we put in that hold the correction in place. But I'm trying to reduce the swelling and the pain and accelerate the healing. And just by slowing you down a little bit, in my opinion, it's totally worth it. So that's the first 6 weeks. After that, as your swelling allows, you can get back into a normal shoe and you can start walking a little more normally. And right around that time point is when I usually recommend driving if it's your right foot, when you're walking pretty normally in a shoe. Because to drive, you need to have the timing and the power to push on the pedal. So in terms of getting back to more aggressive exercise, like walking many miles, running, it can take a little bit longer. Again, we do, even though there's small poke hole incisions, we're still cutting the bone and that bone has to heal. And it takes months and months and months for your body to make that bony union of that cut bone really solid. So much so that if you're a marathon runner, for example, it could be 6 months or even a little bit longer before that bone is solid enough to where it doesn't swell up and get sore on you when you run. But usually by 3 months, patients are walking considerable distances without a lot of pain. It's more the high impact, aggressive exercise routines that can take a little bit longer. Did I answer all the questions within that question, Caitlin?
Yes, I think just what about doing surgery on both feet at the same time?
Right. Personally, I don't recommend that. We certainly could do it, but it's nice to have a well foot to put all of your weight on. It's tough to be heel weight bearing on both sides. It's just an easier recovery when you have one foot that you can depend on to get around, and it makes it a little bit safer. So my typical recommendation is to do one side at a time, and I usually recommend the side that's more painful.
Okay. A couple questions about anesthesia. So do you have to go under anesthesia for the surgery? And if so, what type?
Excellent question. That can vary based upon your medical history and the preference of the anesthesia provider. But in almost every case, I do what's called an ankle block. Once they give you a little sedation in the operating room, I inject some numbing medicine around your ankle. There's multiple nerves that kind of give all the sensation to your foot. And I know where they are because I've been trained to know where they are. So I inject numbing medicine right around those nerves so that they don't have to use general anesthesia. and put you totally to sleep. So we can usually do this under what's called LMA or lighter sedation, because you're not feeling what I'm doing during surgery because I've numbed up your foot.
Okay. And is this an outpatient procedure?
Yep, in almost every case, this is an outpatient procedure. Yep, you can go home the same day, and like I said before, you're putting weight on your heel for balance and to get around.
Okay. Couple more questions. What if a more advanced deformity is noted when doing the minimally invasive surgery? Would you then have to do the open surgery, and would you do it right then?
Yeah, so we're usually able to make that determination in the office. That's not usually something that's a surprise in the OR. We do a very comprehensive exam to understand how flexible the deformity is and get an understanding of how severe it is. We also look at it under X-ray. So we're prepared before we go into the OR to do what we have to do. Patients that are borderline where I don't know if the minimally invasive surgery is going to work, is that possible? Sure. I could say I will try to do it this way, and if we need to do something more traditional, we certainly can. But in most cases, we know from the preoperative exam, from being thorough, that they're going to be a good candidate for the surgery, and they can be confident that this is the surgery they're going to get.
Okay. And how long does the surgery take?
For the patient, it feels like a couple seconds because of the anesthesia. For the surgeon, it just depends upon what we're doing. Sometimes we have to make one bone cut. Sometimes we have to make a second cut distally, as I showed you with that other screw. Sometimes we're addressing the other toe. So it can be really variable. But for a more straightforward case where we're just addressing the big toe, sometimes it could take an hour, hour and a half. Sometimes it can take 40 minutes. But if we're addressing multiple toes, it can take a little bit longer.
Okay. Are there ever situations where someone wouldn't be able to go home the same day of surgery?
That's a good question. I guess in some cases where someone might not feel comfortable walking around on their heel, if they have balance issues before surgery, and they would feel more comfortable staying one night, for example, or we have physical therapy evaluate them after surgery and see if they're able to safely walk around. In those cases, if they weren't, then it may not be a bad idea to stay in the hospital for a day or two and work with therapy. But in most cases, patients feel pretty comfortable and pretty confident going home after surgery because they are able to put that foot down as a pivot point and as a point of stabilization.
Okay, and let's see here. Are there any situations where you wouldn't recommend surgery? Like maybe someone has another condition on top of a bunion, like maybe they have rheumatoid arthritis.
Sure. I do a very comprehensive history and exam with all of my patients, and there are certainly some conditions that make surgery a little riskier. And if you have one of those conditions, we'll talk about it, and we can figure out what makes the most sense. There are some conditions that maybe make a minimally invasive bunion correction less predictable. If you have a severe bunion deformity in the setting of rheumatoid arthritis, well, we're probably going to be talking about a big toe fusion. Because I know that's going to be a better answer for you in terms of correcting your bunion, it's staying corrected, addressing your pain, and addressing your deformity. But I'm happy to see anyone in the office and talk extensively about their medical history so that we can make the best decision for you.
Okay. I've got some more questions here. Can you just shave the bunions down?
Great question. We get that question all the time. And I'll go back to this slide here where, it's a very, you look down at your foot and you see this prominence of bone, right? I'll pull my cursor up here. Sorry, it was freezing. You see this prominence of bone and you think, if we could just shave that down, wouldn't everything go away? The answer is no, unfortunately, because you need a lot of this bone to articulate or to form your joint with this bone. So we can't be too aggressive in removing this bone. Furthermore, it's not going to correct the root cause. If we were to shave this part of the bone here, this bone could shift over even further and we could still have a problem, and your big toe can still go the other way towards your lesser toes. So we usually, very rarely are we recommending an isolated, what we call medial eminence removal, because it's not addressing the root cause of the problem, and we're concerned that someone is going to have symptoms again and their problem could get worse.
Okay. Would you encourage a potential patient who has inflammation on the pad of their foot and possible bunion issues to make an appointment with you first, or would you suggest them to visit their primary care doctor first to diagnose?
Sure. I'm happy to see you at any point in time, whether you want to schedule with your primary care physician as well, but a lot of times the calluses and the inflammation of your foot can be a result of the deformity. So I think it's a great idea for me to see you. And if there are any concerns that I have, medical concerns where I need help managing those conditions, or I think we need to treat a medical condition before we talk about a surgery, I can certainly tell you that. And I can certainly say, hey, why don't we go to your primary care doctor first? But a lot of times it's the mechanics of the foot that are causing that inflammation and those calluses.
Okay. Post minimally invasive surgery, do you have to stay off your feet the same way you would in traditional surgery?
Good question. Every surgeon has their own protocols. So it's hard to answer that question perfectly. But when I do different types of bunion surgeries, like a big toe fusion, I do go a little slower with patients. I'm a little more cautious because what I'm asking the body to do is a little bit different, right? I'm making a bigger incision. I'm stripping a little bit more of the blood supply from the bone, and I worry that if they're moving too quickly, that things aren't going to heal okay. And thankfully, with minimally invasive surgery, that's a little bit less of an issue. But every surgeon has their own protocol, and like I said, there's over 100 procedures, and different procedures have different advantages. So, but for me personally, my rehab protocol is a little faster for a minimally invasive technique compared to a more traditional technique.
Okay. And then after surgery, are crutches or a walker or anything like that necessary?
Good question. It certainly can't hurt. Some patients are very comfortable walking around on their heel and they feel steady, but if you feel unsteady at all, it's a really good idea just to have an extra point of stabilization, whether it's crutches or a walker. So almost routinely, I recommend that you at least have them around. That way, if you do lose your balance, you're not falling and hurting something else.
Okay. I think last couple questions here. Are there any lifestyle changes that need to be made after surgery?
Sure. Well, that can be different for every patient. There are some patients who come in to me because they like to walk the boardwalk for exercise and they can't do it because it hurts. So I'm hoping they can get back to doing that. There are some patients who would like to wear certain types of shoes. I certainly don't tell a patient what they can and can't wear. Although after a bunion surgery, even though we correct the deformity, there are certain shoes that still may not be so comfortable. In particular, I get questions about high heels or shoes with a little bit of a lift. And most patients tell me they're comfortable with a heel that's about 1.5 inches or less. Something higher than that can still be a little uncomfortable, but if you can wear it and it doesn't bother you, then certainly go for it. But in most cases, we're not restricting you going forward. We're doing the surgery because we want to remove those restrictions and keep you active and get you back to things that you can't do anymore.